Right, so we are ready to start again. We've talked about society, we've talked about treatment, and I thought it was very important, and Susie thought so as well, that we should talk about the question of training. All of the models, if they work because people have been trained to understand how difficult it is to deal with a disease such as addiction. It is a brain disease, it's a chronic disease, it's a disease that is very complex, very difficult. The success rate is so-so, not because we're not working well, but because it's a chronic disease and it's all in the name. So it starts again and then starts again. And so it's very important to think about how do we teach that? We've talked about humanity, we've talked about the group. We've noticed for the past 20, 30 years that the group approach is very much central to the notion of treating addictive behavioral issues. So the idea of addiction is a problem that is very, very important. It's something that takes place in your head, in your heart, in your whole body. So I have Susie and Rani with me today. I think both of them accumulate probably about 50 years of experience. It's not bad. And we can talk about that later on. But anyways, and they both wanted and have been wanting for a really long time to transmit what they have learned, to share what they have learned with a new generation of therapists. They want to talk about how to deal with addiction in a humane and efficient manner. So I think it's really the right moment and the right year to talk about all this. Susie and Rani both work and have been working together for a very long time. I think we all know how much they have done in order to try to alleviate human sufferings, and I think it's really, really very important. I'll just leave the floor to you. Yes, thank you, Christophe. Thank you. I'd like to thank iCAAD for being there, for supporting us, for making it possible for us to talk about that very interesting theme. We're both very passionate about it, have been for a long time, and it's sometimes a bit difficult to talk about training in France, but we're making progress step by step. My name is Susie Longbottom. I'm the head of the department in Aubervilliers. I'm part of the Aurore Association. My facility is as well. In the past, I've worked for years actually with the APT Association, which now merged with the Aurore Association. So my center is part of a partnership, and we are going to talk about the history of that partnership in a second. Yes, hello. I'd like to thank iCAAD as well for inviting us today. My name is Rani Duprat. I have been working for a very long time with Susie. She trained me for me to become a counselor about 15 years ago. I've worked in the APT Center, and I've worked in the treatment community in Aubervilliers. I try to I'm sorry, I'm not very good at using the microphone. And I've been working very much with carers, with families, and I'm very interested in training, which is a theme that I have been working on with Susie. On the first slide, obviously, there is something missing, and that's addictology counseling, the French model, because this is really very much important for our presentation. What do we want to do? What are we doing? What is the French model? How can we create it? How can we integrate it in a lot of different institutions, maybe all institutions, or at least a large part of our French institutions? So we're going to have a look at the state of play in terms of counseling and training, and counseling training also in France. And then we're going to talk about counseling in and of itself. To what extent is it a relevant approach in the field of addiction, and also to what extent is it a relevant approach to train former addicts, former drug addicts, or other addicts? We've been hearing about that quite a lot, professionalizing users. To what extent does that approach help provide a proper training and efficient training for people who have gone through recovery and addiction. And also there's that question of group therapy, group support groups, and that's at the very heart of our project, and we'll talk about how that fits into what we want to set up today. Yeah, now addiction counseling is something that has been taking place for the past 25 years in France. And I believe Jean-Maxence talked about it a little bit before when he spoke of the 4 institutions that deal with counseling. And the APT Center decided, with Kate Berry and her experience in England in '93, they decided to try and import that model, a model that, I guess all of you know it, it's a model that had been in place for about 50 years in England and other English-speaking countries. So in '93, again, we started putting it in practice, practicing counseling in France. That was about 25 years ago, and I have been working more or less in that field for the past 25 years. We now have 4 institutions dealing with counseling, 3 institutions in which counseling is at the very heart of their practice, and a 4th institution, so the APT Center, the Community Therapeutics in Aubervilliers, the Residential Center Edivion in the Val d'Oise, and then there's a 4th institution, which is the Psychotherapeutic Clinic of Uni, where they use counseling in parallel to, or as a complement to, a medicated psychiatric and psychotherapeutic approach. Since '95, so since the beginning of the APT Center, rather quickly after the creation of that center, we understood that it was very important for patients to be able to continue working in that field. So starting in '95, we created training sessions internally. So we implemented and supported training sessions. So that took place between '95 and 2010. We organized 5 training sessions. So that represents about 100 people. 100 people were trained, and one of the particularities is that the trainings were mixed, which means that you had former drug addicts, you had people who had stayed at the APT Center, but also people who were working in the medical or social environment, doctors, people who were working in the justice system. Those were training sessions where we had it was a mixed bag of participants, and I think we wanted to really keep that going, that very diverse aspect. And those were trainings that were based on, basically the idea was to have 15 months, 2 days of theoretical training, and then several practice hours in trainings. I think they had to spend a week at the center in immersion. So they went to the center, you left your phone and your books at the door, and you spend a week in the center to go through the same experience as what the residents were going through. I'm sorry, I'm a little bit confused. So once you had gone through that training session, we tended to ask people to work 1,000 hours in the center as an internship, with a very solid framework around them. It's, of course, very interesting to have a theoretical training, but practice matters too. So we have that particularity that our trainees had to work for 1,000 hours in practice before they were allowed to work as counselors.
The limits of this experience. So this experience led us to 2010, and with the merger between the APT Center and the Aurore Association, we took a moment to think about what was relevant, what was germane in this way of training people, and what was not appropriate. So there were quite a few limits to this experience. We thought, both of us, deeply about what we should do going forward. What do we keep and what do we abandon? And there was the fact that at the time when you do internal training, you train people to work in the center where the training is conducted. So that's a fairly significant limit. It's not a course that was recognized beyond the association. It was a course that was focused on how we work within APT. It wasn't intended initially to train people to go work outside in the rest of the world. So, however, we did have trainees who came to do the course because the approach interested them, for them to roll it out in their centres. But we didn't train them for that. We trained them to give them a vision, a way of working. But it wasn't intended for them to export counselling in their centre. There was no supervision either. So when we started working as counsellors, we needed to get supervisors from other professionals. There's no supervision though. So once you finished the course, you found yourself in the field, and you were just let go, and there was no way of taking a step back and looking and analysing your approach. And that's something we thought about to support people who came to work in our centres in the future. And that's also something that some people noticed in training in England, who shared this with me. Even in other countries, we saw the same issues. If you're not capable of approaching what's going on behind the closed doors in individual relationships, or looking and even in group counselling, there can be significant issues going forward. So it's a subject. The aim was to train counsellors working in centres with a method adapted to the centre, whereas that was in the past, and now we're thinking about counsellor training in a larger sense, in the wider sense that it can be exported to areas that are not necessarily focused on a counselling project. What else can we say about the limitations? There's also what Philippe just told us. Thank you, Philippe, because he did the course with us. The aim of the course was to talk about counselling, its application within APT and maybe within other institutions. They're using the Minnesota model, but it didn't give an overview of the context or history of drug use in France. So we asked at the time all trainees to do a university degree, to give them this knowledge, this know-how. So we started working on it again recently, Rani and myself, with our teams, with the teams I work with to discuss what we're going to do going forward. We're all approaching a sensitive age, if I may say, maybe approaching the end of my career. For me, in any case, it's something I want to do with it before I retire, is to pass on all this long experience in a structured way, to ensure it's profitable for future generations. So initially we decided to come out of our isolation and go towards structures, institutions that could help us carry this project. So we approached the Addiction Federation to talk about this future project and the issue of recognition. Do we do this work with universities, or should we work with other bodies that can award this future diploma? what should we do? So to start with, we set up with the Federation of Addictions 2 awareness-raising sessions on addiction counselling. So one which was held in November of last year, a 3-day course, 3-day session, and another one which will be held in June of this year. We're going to say a word about this session, and I just wanted to say, since the counselling has been practiced in the centre in Aubervilliers, there's more visibility, and there are other requests from other therapeutic communities and other bodies to be able for them to take this practice into their institutions. So we organised this 3 days of awareness raising, which was very dense, because we wanted to put a lot of material in it. But with the specificity of this is that we put the trainees in situation, in counselling simulation with groups who we asked, and we asked them to work as professionals, but also as a member of the counselling group, and we got them to work it together on what their experience with the others. Can I say who I am? It was very enriching, and I think the people that the people who took part in this course talked about this experience and this possibility of bringing each other different things by working in a group and by changing places within their group. So we have prospects for a long-term course with the institution, because we don't know, you can't train someone to do counselling in 3 days. This is what Rani was just talking about, was awareness raising. But to talk about ideally what should be contained in this training, but we're working with the Federation and maybe CNAM also, with the prospect of approving a future course. So we talk a lot about counselling. I'm not sure if that's clear for everyone what this means, because it is a term that we didn't define earlier. But in France, the history of counselling started in the 80s with group therapy, peer support group that use counselling for people who are affected by AIDS, in particular, for the loved ones who also were part of this association. We also created these groups. There was no addiction counselling. So we talked about earlier about the professionalisation of drug users. Counselling is an approach that allows us to train people that have this experience, and what we can see is that it's real advantage to have people who have this lived experience. But people ask me, if you have former drug users, what are they there for? Is their role, do they have a clearly defined role? What training do they need? And what are the expected benefits for the institution and the team? What can a person who's a former user bring to the group? So, of course, this is not the case of expert patients. This is not the example of a drug user who would use this experience to talk about drug use with people in the organisation. What we're offering is a framework of relationship and help. So a professional approach, and just to specify, counsellors today can talk about their history, their past, from time to time, but it's not the core of the practice. The idea is to help users to think about their past, their background, and pass this on to speak about it with drug users in order to help them think about their drug use. This approach will focus on the relationship with the product. For many people in different practices and treatments, addiction treatment in France, it's not at the core of the support process. So this is something we think is different. It's different because we really want to analyze closely how the people's relationship with the product is. How do they perceive this relationship? What is the role of the drug in their life? And why do we do this? It's to provide teams with a perspective of this experience on weaning, to make sure that this experience is part of the team's work. For example, yesterday with Susie, we were thinking of examples. Somebody earlier was talking about withdrawal. Somebody with an experience of withdrawal symptoms will know that withdrawal is not just a physical thing. It's psychological, and they will have the experience of the feeling of withdrawal, how obsessions can become, how you need to grieve the product. Are there issues on sleep? They may even be able to identify when these things happen, even if people in the institution don't talk about it. So they can talk about this. They get people to talk about these issues. So let's carry on. This is also to help people become aware, because once people have been weaned off the drug and they've felt withdrawal, they also need to be led to become aware of what they do to remain abstinent, but also to replace drug use with other things in their life, in particular satisfactory relationships, and that's the main subject we're going to present later about group work. What we want to do is to ensure people develop aptitudes to develop group support on these issues, and this is where our approach is situated. We need to get past the symptoms and stopping the symptoms. Beyond that, there's reflection that is needed on who I am and how am I with my relationship with others. And if I don't see how I act in relationships with others, that can be a cause of a relapse. And so satisfactory relationships, the point of relationships are not just to have nice relationships, it is also to enable a sustainable recovery. That's another way of looking at things in any case, and that's what we will focus on in the course. And it's also necessary to prevent relapse. Someone who has developed satisfactory relationships will be far better equipped to prevent relapse. So this experience, as a former user trained in counselling, will help to define relapse prevention at every stage of the continuum of care. For example, when I talk about Aubervilliers, I say we, because it's there's a strong level of attachment, even if I don't work there anymore. But we saw people who had a fantastic experience. It's 2 years that they stay there, but we noticed that what they established in the centre wasn't sufficient to help them afterwards. And when they went back to work, they relapsed. And we realized that there wasn't this ability to establish satisfactory, supportive relationships to allow them to maintain them outside of the centre. It's important to say that it's maybe a trite expression, satisfactory relationships, but it covers a lot of things. But if we analyse what we experience with the people we have in our care, having a satisfactory relationship means having a relationship without rage, internal rage or resentment or injuries, personal injuries, interfere with the way they build their relationships with others. It's really at the heart of this relapse prevention work. So what type of training? This is what we want to do and develop. This focuses on the former user and their experience as the starting point. But it needs to be clear that this course is not just for former drug users. What we want to do with this course is not possible if we're just talking about former drug users, but that's the starting point. And it's this work conducted with a former user and with other counsellors that we can help to build something with a very enriching content for anyone who wants to be trained up in counselling. So it's important to talk about your experience, their experience, and to conceptualize it. There's something done with other professionals. It's not just what a former drug user does on his own. That's a very important point for me, because if you're not thinking about your own experience and trying to extract something to help you develop tools for people to help them work on themselves, you can have difficulty stepping back. It might be you might have experience. You might have the feeling that your experience is everyone's experience, but that's not the case. There are common things, but everyone's experience is individual. So it's important to have this time to conceptualize. It's not when. It's not in the field that you'll do that. It's that you need to take the time to think about your personal experience, and that's central to the course. And I think it'll help former drug users. I hate using this expression, but we'll use that. It'll help addicts when they find themselves in group therapy or conducting a group therapy session. They'll know that if they're talking about their experience, that's one tool among others, but it's not systematic answer to everyone's solutions. So the second approach to training is group therapy based on interpersonal relationships and the possibility of change. I just want to add something here, the idea of conceptualizing one's experience, to think about it and talk about it with others, and being able to interiorize it as something other than a personal experience. This may seem obvious to you, but this is an exercise which takes time, that requires feedback loops, which requires practice, and is acquired over time. And this goes both ways. Professionals that don't have the experience, close experience of drug use, because they have a different experience, different background, different knowledge, what can they understand from the other person's experience? They can't hear it if it is just a lived experience. They can hear it and use it themselves, because it's something that you can think of collectively. That's very important in our course. I've experienced this in training, and with the teams I've worked with, we can have a kind of separation. You can have some people who are experts. On the one hand, you have experts of addiction experts, drug experts, and on the other, employees, who are other professionals who care experts. So that's not our approach. We want to put everyone together and to promote the idea that people learn from each other. They learn from each other, not just former drug users learning from the teams or vice versa. There's a real collective knowledge, construction of a collective knowledge, and this comes from the idea that in counselling there's a as a counsellor, the know-how is with the drug user. As a professional, I'm not I don't know. It's the other. How do I get access to this know-how, and what can I do with it to help me as a professional, to help him recover? That's still our approach and our starting point. In training, we have noted a few specific points, not the only ones, of course, but something we need to highlight. The fact that we need to work on weaning. What happens when you stop using drugs? In Bouverlier, the part of the experience that was very interesting was the stoppage of using replacement drugs. There's a lot of people who get to Aubervilliers saying they want to finish their replacement therapy. They're using Meta or Subutex, and this weaning can take place over several months, and they'll have support in doing that. And the clinic, drug use stoppage clinic, or the replacement therapy stoppage clinic, has things in common. There's this fear of stopping, the fear of the final dose, the final substitute dose. So there are lots of things that they work on together. There are lots of points in common. And there's also unique points. I think the only institutions that works like this is Aubervilliers. So this is something that comes from our experience in Apt, but was greatly improved, and we've worked on it in the last 6 years since this centre has been open, and it's something we want to really formalize and continue to develop, because it's singular, a unique approach, and it's rarely implemented, and I want to do it with the other communities here. I think maybe other communities here today can benefit from this. So mutual support mechanisms, briefly. We talked this morning about mutual support, and what we wanted to do in this course is to help carers, bearing in mind that the solution is in the drug user, learning to put people together, drug users together, so they can find solutions together. We have a tendency as professionals to think that we have the answer, but our approach is the opposite. How do we promote discussion, and how do you allow expertise and solutions to emerge in drug users? And this doesn't come from the professional. It comes from the fact that they have group therapy, that they're in relationship, they're in contact with other people. So we're going to move on to the role of emotion in therapy, in counselling, and this is an important aspect of training for us. So what are the benefits for the teams and the institutions? This close relationship that's established between drug users and counsellors and former drug users who are trained will give us better understanding of the processes that they're going through. And if they're well trained, it'll allow us to eliminate this idea of a common identity of the drug addict. There is a therapy little by little with the support of iCAAD maybe to move towards the possibility of training people with the involvement of Hervé Yalom and some of his most important work. And he uses this group therapy model in many institutions abroad. It's very relevant for addicts. And it's also the model developed by Flores, who speaks about it in her book. How relevant it is for addicts to be in contact with other addicts and to discuss, because addiction is an issue, a problem of relationships. Here we have a little diagram that briefly shows the intervention of counsellors will not be as the group as a whole, or a single individual who's working on their long-term problems with a question mark on the causes. This type of approach will be focused on interpersonal aspects and the learning through discussion with other people on how I experience my relationships, or how I am in my relationships. And here the aim is learning, and also maybe making the changes you need to have satisfactory relationships, in inverted commas. So this type of work will be focused on group therapy and this group dynamic. That's the aim of this is what happens within the group. It's not what happens before, what you think afterwards. It's what you experience on a day-to-day basis in the discussion in group discussions. It's work that requires training in group therapy to achieve that objective. I also wanted to say that it's important to have this framework for group therapy over long periods. I don't ask each people to go back to their individual personal injuries. I'm working on the relationships with other people. How do you react to what other people say? How does what you say affect others? The work is really focused on that. I know it's difficult to do that if you don't have a clear framework, because maybe you want to do something else, to work on other things than interpersonal relationships. It requires a solid framework and training to get back to refocus on that, and that's why the Yalom model allows us to acquire this solid structure to manage groups and know what you're doing in the group, and change. We're not changing for the sake of it. The aim is to think about who you are differently, and to be able to perceive yourself differently, you need to understand that other people see you differently from the way you see yourself. If you think you're rubbish, you're useless, you can't move forward. But if someone else sees you, says, I can see how you are with me, I can see the love and support you're capable of, that you can change people's the way they perceive themselves. And it's difficult because if you have an addict who has no more drugs to feel to get this support, to make them feel the better, to get even for someone to hold up a mirror to themselves, or to have a direct conversation, that can be difficult for them to stand. It can be difficult for people after years. I know we have trainees here who can talk about what they experienced in November. Talking about yourselves. That's what we do in training. What we do with drug users, we do also with our trainees. So we get them to experience this group dynamic, and it's painful to be facing you to be sitting opposite someone telling you how they perceive you, but it's essential to understand what drug users experience and the resistance they may have to it, and how this resistance can interfere in your work, and it becomes very powerful. And when you're in it, that creates powerful relations, strong relationships. So this work by Irvin Yalom helps structure the therapeutic work, the evolution, the different stages. It offers standards, therapeutic factors that supports the approach, and provides very clear objectives for the work. And it gives tools. If there's a group is not working anymore, you can use different approaches, different tools to reboot the group. And when you have long-term groups, for example, when people stay together for a long time in a group, they don't know why they're there anymore. So you need to know exactly where you are to restart the dynamic.
So far we've, I'd like to talk about the means that we give ourselves in this training. We have a training model that helps us transmit skills and know-how between professionals and former users. So we try to learn how to use our experience and to acquire new experience as well. And I think that's very, very important with regards to that problem of addiction. It's difficult for us sometimes to talk about the strength of our experience. Some people here might already have gone through similar training or laboratory training, but it is our wish to create a proper instance so that we can promote it, not just because we want to use it in different institutions. We believe that it could also be that counseling could be useful in several medical and social facilities at several stages in the management and the treatment of addicts. It could be used in daycare centers, could be used in post-cure, as a post-cure solution, could be a good way to support people once they have left the facilities, and to also provide support for carers in some cases. I believe that this is more or less all that we had to tell you today. If you have any questions, obviously, maybe we can take them later.